Let's go ahead and get started. So it's my pleasure today to welcome Dr. Joel Manyahi from Muhimbili University of Health and Allied Sciences, visiting from Tanzania. We've been longtime collaborators, and for those of you who are in the earlier session, you know that he's also worked closely with Dr. Annika Hooft in pediatric emergency medicine. He is the head of the Department of Microbiology at MUHAS, and is an MD, and also got his PhD in microbiology at the University of Bergen in Norway. Has incredible work with antimicrobial resistance across both adult and pediatric populations. And today he's going to tell us some of the clinical consequences of multi-drug resistant infections, specifically in pediatric patients in Tanzania. So thank you very much for coming.
So thank you, Teresa. Good afternoon again. So this afternoon we'll discuss some of studies which I've been doing. I've done Tanzania, and some of the work which I'm currently doing in Tanzania, mainly on antimicrobial resistance in children, but I'm engaging both adult and children, addressing MR. That's my area of interest. As Teresa mentioned, I did my PhD on antimicrobial resistance in people living in HIV. So it's an area where I enjoy doing my research. So I'll quickly just talk about studies on colonizing multi-drug resistant bacteria, which I've done in children, and then studies on antimicrobial bacterial infection and their outcome, and the effort which we are doing in Tanzania to address MR in our national action plan, and then I'll give a conclusion. So I'll start the study which we did, which we published 2 years ago. Okay. Which was published two years ago, where we randomly enrolled 200 patients, 100 with confirmed bloodstream infection, 100 without bloodstream infection. We corrected stool, and then we screened for extended spectrum beta-lactamase producing Enterobacterales. This study was conducted in Dar es Salaam. Dar es Salaam, it has 5 municipals, so samples are coming from all these 5 different hospitals. Of course, there are 5 hospitals, so samples are coming from those hospitals. And what we found in that study, I don't know if you could see, but overall prevalence of extended spectrum beta-lactamase producing Enterobacterales colonization was 56%, and was higher in children between 4 and 6 months. And the children with bloodstream infection had higher colonization with SBL compared to those without bloodstream infection. You can see p-value 0.02. And we also compared, because we have confirmed isolate from bloodstream infection. So we compared isolate from bloodstream infection and the colonizing isolate. We just look phenotypical matching, like a suspected profile. So we found 16 pair of SBL isolate from the gut and from blood were similar on antimicrobial profile. We could do molecular typing, like checking sequence typing or SNPs, but only based comparison based on a phenotypic characterization. So we thought colonizing pathogen were the same causing infection. So always colonization is a prerequisite for infection. And the most predominant ESBL gene which detected CTXM, and this has been common in study which we've done in Tanzania. CTXM15 has been predominant gene which we have been detecting, studied in adult and even children. All the study which were performed, we found the predominance of CTXM15. Also, another study, this part of my PhD, we screened it, 500 HIV-infected adult and about 2,000 stool of children's. We are screening for both ESBL and the carbapenems producing genes. And we reported from the first time, from 3 days, infants were colonized by NDM5 producing antibacterials. Of the children, 2,000 children screened. 2 children were colonized by NDM producing Escherichia coli. So, and we found ST167. This is highly virulent strains where colonizing these children, and the blood NDM5 coexisted with CTXM15, and those were carried in plasmid. So you could see there's high chance of horizontal transmission as gene were carried in the plasmid. All these isolate, this ST167, were also harboring a gene for resistance, gene to other antibiotics like fluocinolone, aminoglycoside, sulfamethoxazole, trimethoprim, macrolide, tetracycline, and the chlorphenicol. Unfortunately, we didn't follow up this patient on the outcome if they develop infection due to the same pathogen, the same drug resistance pathogen. But we are pretty sure this is quite worrying when you see 3 days neonates colonized by these multi-drug resistant strains. And at the time when we were reporting our study, it was, I think, among this was 8th country in Africa reporting for the first time this NDM5 isolates. So you can see previously were reported in North Africa, and then Nigeria, Cameroon, and Angola, South Africa, and then Tanzania reported it was the first gene. But we couldn't analyze further either was imported or, but definitely NDM5 has been commonly reported in Asia, especially India, and there is a movement between India and Tanzania. Also, most of our patients they are referred to India to receive treatment, so possibly was transmitted from that region. But also, we checked another study where we assessed SBL producing isolate, we screened for fluocinolone resistance. This study was published a year ago, and because fluocinolone are commonly used in Tanzania nowadays for treatment of many bacterial infection, so SBL producing antibacterials isolate were tested for quinolone accessibility using both disk diffusion and the minimum inhibitory concentration, and randomly selected about 40 isolate, and we subjected them to whole genome sequencing to see what kind of fluocinolone resistant gene were carrying. And we found almost 90% of phenotypical fluocinolone resistance SBL producing isolate harbored one or more plasmid-mediated fluocinolone resistance genes. And the most predominant sequence typing was endemic strains, ST135. and this has been associated with the pandemic infection worldwide. So this is a study which we detected multi-drug resistant strains colonizing the gut of neonates and children in Tanzania. Also, I was involved in other multi-center study, which we did at Muhimbili National Hospital and other referral hospital in Dar es Salaam. In Dar es Salaam, we have 3 referral hospitals and the Muhimbili National Hospital. So this study involved the 4 hospitals where we enrolled more than 2,000 children aged less than 5 presenting with fever, and we performed the blood culture, and also we did malaria, rapid test for malaria and blood slide. And we found out of 2,000, 11% of our children had confirmed bloodstream infections and 10 had the malaria. And we found that 50% of gram-negative bacterial infection, which are causing bloodstream infection, were SBL and also multi-drug resistant. And of staph aureus causing bloodstream infection, we found 26 were MRSA. So this patient needed to be treated with vancomycin, and vancomycin is quite expensive. And the overall in-hospital mortality was 4% in this study. And it was high in children with bloodstream infection compared to those with malaria. And in our multivariable analysis, we found that bloodstream infection was a risky of mortality. So also recently published this study in +1. We did a case control study at Muhimbili National Hospital, where we enrolled the cases where a patient with polymicrobial bloodstream infection, and control were a patient with monomicrobial bloodstream infection. We matched the case control by age, admitting body, and duration of admission. So matching of 1 to 3. And we found that overall isolate, which was relatively were frequently multi-drug resistant bacteria, and the 30 days and the in-hospital mortality were 33 and the 36 respectively. But again, we found that polymicrobial bloodstream infection was independently risky for mortality in this population. So initially, first, we enrolled the pediatric and few adult and neonates, but then we did sub-analysis to neonates only. And we still found that polymicrobial bloodstream infection was the independent risk factor for mortality in neonates. For both 30 days mortality and the in-hospital mortality, and the overall median duration stay was high in patients with polymicrobial bloodstream infection compared to monomicrobial bloodstream infections. Also, we published this study where we were looking for etiology of wound infection in patients with burn wounds. And we collected swab from 103 pediatric patients with burn wound, and a total of 136 bacteria were isolated. And again, we found most of the bacteria which were isolated from this wound were multi-drug resistance, with high proportion of extended spectrum beta-lactam producing isolate. More than 78% of gram-negative antibacterials were ESBL producing. So you can see we have this huge burden of multi-drug resistance causing bloodstream infections. So we also have some, I've been involved in some this study has not been published. We did a randomized clinical trial in northern Tanzania, where we were looking the effect of probiotic in preventing both mortality and the hospitalization. So the primary outcome was composite outcome, death and hospitalization during the first 6 weeks. And the secondary outcome was colonization with SBL and the infant growth and adverse outcome. So we enrolled newborn with more than 2 kilograms, and from 3 days, we gave one group was given probiotics, and one group was given placebo for 4 weeks, for 6 weeks. And then we first collected stool at 6 weeks and 6 months. And then in total, we collected more than 4,000 stools. And this tool was screened for SBL. And then the primary finding, and we found there's no difference in the composite outcome of death and hospitalization between probiotic and the placebo groups. But we found that using placebo probiotic was preventive in colonization with SBL. So was protective. If you use probiotic, you found these children were protected against being colonized with SBL. So this study has not been published. I think we are working on it soon. We send to the journal for see if it gets published. But it's quite interesting finding. And then also, this also study has not been published. We analyzed 12 phenotypically carbapenem resistant Klebsiella pneumoniae from neonates, from 9 patients in total. There are neonates, children, and I think 2 adults. And then we found that this 12 isolates, 6, there were 7 isolates which carried NDM5, and 6 had the same MST sequencing, and 1 had novel ST sequence type. And the resistant carbapenem in 6 of isolate was mediated by a coexistence of 2 genes, BLANDM5 and the BLA-OXA2. And the 1 isolate carried, 6 isolate had the BLANDM5 and the BLA-OXA181, and 1 isolate has coexistence of BLANDM5 and the BLA-OXA232. And the other isolate also had a mutation in outer membrane protein. So out of those 9 patients who had infection due to carbapenem producing genes, 8 of them died. Yeah, so it's quite interesting, and we need to analyze more data. I think this genes maybe is endemic in our setting, but we don't do molecular study a lot. So, but it could be quite common in our setting. Those are only few isolates which are unable to perform whole genome sequencing because of it's quite expensive to perform whole genome sequencing. That's why I did for few isolates. And recently, with support of Teresa, one of my students who survived, who are doing study in ICU. Diagnosis of respiratory tract infection is quite challenging in our setting. So we decided to collect endotracheal aspirate try to diagnose the bacterial cause of lower respiratory tract infection. So we enrolled about 88 patients admitted in PICU, and we collected trachea aspirate and the blood culture. For both we performed culture, and we found that out of 88 patients with clinical diagnosis of lower respiratory tract infections, 63 laboratory confirmed lower respiratory tract infection. So we did quantitative culture for trachea aspirate, and the overall proportion of bloodstream infection was 18%. But only 27 of patients had growth of the same bacteria from blood culture and trachea aspirate. Those based on comparison of only 27% had the patient had growth in both blood culture and trachea aspirate, but only 20 had the same bacteria from the blood culture and trachea aspirate. That's based on phenotypic characterization, but you need to dig further, perform molecular study to see if are the same sequence typing and the maybe SNP the same. So we could definitely say the same bacteria causing respiratory tract infection or the same causing bloodstream infections. And the overall mortality was 51, so more than 50% of patients. And this study died. And the mortality was more frequent in patients with both confirmed bacterial confirmed lower respiratory tract infection and the bacteremia. So this study we are yet to publish. So we've just all the study I'm just explaining burden. So this is a problem which we are having, but we need to find a solution. Is seek to isolate NDM5 producing bacteria from an infant, from neonates. So we are at national level, we are trying to address the issue of antimicrobial resistance. We have a national action plan. The first national action plan was 2017 up to 2022, but now we've developed the 2023, 2028 national action plan. So I'm working with American Center for Microbiology to implement Framing Fund country grant Tanzania. The Framing Fund supports the country to perform MUHAS surveillance. So the support in terms of reagent consumable and the infrastructure with One Health approach. So they're supporting human health as well as animal health. So with support of Framing Fund, we've been able to establish a network, a surveillance network. For human, we have 11 hospitals, including a national reference lab. And for animal health, we have 5 labs. And the agriculture, we are recently enrolling 1 agriculture lab in this network of surveillance. So the focus of the grant is support MUHAS surveillance, but also implement MUHAS activity. Also want to establish the burden of disease, in some of the hospital, and address the issue of gender inequity on antimicrobial resistance. So I will just project some of the, these are some facilities which on this network. And this chart shows just contribution of sample from different facilities. You might not know them, but they're different parts of the country. So network surveillance, we consider geographical location of the country. So at least in each zone, there is a facilities which is part of the network. So the aim of this Framing Fund just to start the country, and then the country itself may take ownership and have more hospitals in the surveillance network. So this is a trend of samples of the blood culture from these 11 sentinel sites. And you could see from this graph, most of the sample are coming from children below 15 years of age. And just want to show some of the data, like the trend of susceptibility to Klebsiella pneumoniae to different antibiotics from where we started to date. So this trend is not good. You could see, for example, meropenem, which is in watch category, nearby blue coloration. You can see most of the is still effective antibiotic. You can see in all 3 years, almost more than 80% were still susceptible, but we don't know what could happen. But you can see for amikacin, it's orange, the sharp drop. But that could be explained when we started. We have very few data reporting, but as we improve on the surveillance, the sample keeps on increasing. The number of pathogen tested, we've increased a lot. So probably we have forced a start, but still see the been sharp drop from 2021 to 2022. So amikacin susceptibility becoming less as here passed on. But you can see the most common used antibiotic, like ceftriaxone. Ceftriaxone is commonly used the antibiotic. So this data from these different facilities. But you can see ceftriaxone by is, I think from down the second one, you can see almost less than 20 of isolate are susceptible to ceftriaxone. So this is worrying. It's not only from Muhimbili, but throughout the country. And this is the first commonly used antibiotic in most to treat sepsis in the country. So, as I said, the burden of MUHAS is enormous in our setting, but they really need to intervene before it happens. First of all, maybe we don't know the impact of MUHAS bacterial infection in our setting, because there are very few studies which has performed the analysis cost impact on MUHAS-related infection. As you can see in my study, there's correlation between MUHAS and mortality. Patients with MUHAS have high risk of dying compared to those with MUHAS. But cost analysis has not been performed. So maybe there's no buy-in. MUHAS is a silent pandemic. It's an individual. I can say it's individualized. It's not like COVID, where everyone was affected. Yeah. So maybe buy-in is not. We haven't showcased the impact in terms of cost, but mortality data are there, and we don't do analysis in our setting. Like we don't put data. We don't have epidemiologists. They don't analyze this data at the end of the day. So it's quite real to know the impact. Data which I have from this small study. Maybe Fleming found also they want to sub burden of disease. So if we collect proof data and then can generalize our finding, but our study will do just small study. So we need to come with intervention. So maybe intervention study, establish a model, maybe which works in our context. IPC is everywhere, but maybe we need to find others, maybe social, cultural behavior also, which may not, which might have impact. For example, in structural design, maybe in most of our facilities, maybe you have one sink in the ward. So just washing hands, washing hands can be very useful in IPC measures. But how often clinician, maybe healthcare workers wash hands. So we need something. What kind of incentive should we do? So we are thinking now, our plan with colleagues, maybe we need to have intervention study, establish a model which could work in our context, try to prevent the burden of this MR. And discussing in the morning that we don't have MOS program, so Framing Fund is trying to capacity facilitate to have MOS program. That there's kind of incentive at the beginning. So if there's impact, maybe the government or facility itself can take ownership and implement a MOS program, which could reduce the impact of MR. And we need a quality improvement project like we did in Muhimbili. We established quality improvement project at pediatric. But this was funded by Pfizer. So after the fund ended, maybe we don't have sustainability of that program which we initiated. And we need mentorship in behavior change because we treat most of our cases empirically, and you can discuss with clinician, but they keep on repeating. So it's more of the change of attitude, change of behavior. So no matter what we might do, but we are in maybe different part of the world, people different attitude. So we might need to think different approach in the context of our Tanzania. So having said that, karibu sana Tanzania. Tanzania is the home of Mount Kilimanjaro, not Kenya. You might heard of Mount Kilimanjaro, but Kenya, they are claiming Mount Kilimanjaro. You can see better, it's more visible from Kenya, but that's not true. Here is Moshi. You can see nice Mount Kilimanjaro. Thank you.
Questions from the room and for those on Zoom?
Dr. Manyahi, very nice presentation. Thank you. My name is Manyahi, the Institute.
Okay.
Very much enjoyed the presentation. Thank you. I had a couple of thoughts when you were presenting. One, what do you know about regionally Tanzania compared to its neighboring countries in terms of some of the burden that you described? Is this unique to Tanzania, or is it based on other studies seem to be similar in the neighboring countries?
Yeah, in terms of magnitude, is almost similar to other country. We have one slide we presented in the morning. You can see the burden of MR. In East Africa, it's almost the same. Tanzania, Kenya, Uganda. So I can say the pattern is almost the same for the region. Yeah.
It's interesting to think about the etiologies and the fact that it's so universal.
Yeah.
Across, no matter changes in resources, differences in communities.
Yeah.
I was wondering whether the national program on AMR and the Fleming Fund activity, that program.
Yes, it's the Fleming Fund is supporting one of the strategic objectives in our national action plan.
And do you know if the national plan has any comments or interest in looking at agricultural sources of antibiotics in terms of herbicides, herbicide usage, from a perspective of One Health? You mentioned, but there's also an entry into our diets, people's diets, herbicides. I wondered if you had any thoughts about that, whether as part of an AMR national plan, that had been considered.
Yes, National Action Plan, it's a mission, it's One Health approach. It considers both environmental, agriculture, animals, fisheries, and humans. So I'd like to know transmission dynamic on this in One Health approach. But the problem we have We have a nice national action plan, but its implementation depends on donor funded, and donors have their own interest. So they can't pick everything. For example, Fleming Fund, they came and said, wow, we're going to support a few animal health lab and the human health lab. And now they've added one fisheries lab. So in agriculture, environment, we are still struggling, but our national action plan, it consider all a key area in transmission dynamic for antimicrobial resistance. Yeah. So if we have funds possible, and we are trying to advocate to the government to set some funding, but that's competing in priority as well. So and it's MUHAS is just a product of something. Yeah, you need to screen and get MUHAS, so it can be done indirectly. So like now we want to do mapping stakeholder of all activity which are done in different aspects and collect data centrally and analyze. Yeah. Yeah. Yes.
How much the spread of the ESBL organism is occurring in the community versus
Yes. So, for example, in my study, which I screened HIV infected patients, they were not coming from the community, they were not hospitalized. And I found more than 2% of HIV infected were colonized with CSPS. Some of them have not even been admitted to hospital. So transmission dynamic can be can be happening in the community as well. Yeah. And I published another study, community tract infection from both community and the hospital. So almost we found equal number of pathogen carrying SBL causing community acquired and the healthcare associated unit tract infections.
the clinical one? Here we see more gram-positive bacteria.
Yeah.
Why there's such? I was just blown away by the proportion of children who have gram-negative bacteria. Why there's such a
In your setting compared?
from your microbiology.
From microbiology perspective, maybe I have no, because most of this gram-negative, the source is endogenous in mostly gastrointestinal tract as source of food. So I can't say IPC measure in your settings. IPC is IPC. Maybe breakdown in IPC measure in that setting could be source of gram-negative. Have no clear answer. But we did a study looking at the pathogen contaminating hospital environment, and we found most common were gram-negative infections. I mean, most bacteria colonizing, most inanimate matter in the hospital setting were gram-negative bacteria, as Netobacter, which is much drug resistance. Enterobacterias were more common than gram-positive. So in hospital environment, definitely those are more common compared to gram-positives. Yeah. But even now, there is, for example, in neonates, we found, if you read textbook, they will tell group B streptococcus, E. coli, Listeria monocytogenes are most common cause. But in our setting, we see Klebsiella pneumoniae, a common cause of early neonatal sepsis. We don't see much group B streptococcus. Could be challenged maybe on identification, possibly, on how we isolate. Listeria monocytogenes, I don't know if you see common in your setting, but we don't report much of Listeria monocytogenes. But I'm pretty sure there could be maybe a challenge on identification, isolating, and identifying them. Yeah.
Why is ceftriaxone clinically reached for as first line if it's has such low susceptibility? Is it more available, lower cost? Why is that the one emphasis?
And that's an interesting question. When I was in medical school, we used to call Parself. That was trade name. So in every infection, this pharmaceutical company will come ceftriaxone. So Parself was commonly prescribed. And so linkage of data with clinical outcome, I think that's one has been missing. Yeah. That's why we thought ceftriaxone magic bullet. So we need to go back to the drawing board and convince clinicians. So this is the data which we are seeing. And we should treat infection based on the source of infections. Like sepsis, every clinician will start with sepsis as a first line. Yeah. Surgical antimicrobial prophylaxis, ceftriaxone is commonly as a first surgical antimicrobial prophylaxis. So we need to highlight the burden and ESBL pandemic in our setting. So it's our work as microbiologists. Maybe we've not done a lot, and we have very few infectious disease in our settings. Our university does not offer infectious disease specialist. So a clinician is more interested with the emerging, maybe cardiology, hematology, and other specialization. But infectious disease, we need a champion in infectious disease who could really play a leading role. I enjoy traveling in another country where I see microbiologists and infectious disease specialists working hand in hand. Yeah? But that is missing in our country. So addressing the burden maybe of MWARA, you can say we need to do more and present this data and showcase the impact. Maybe we start then, like we are trying to develop guideline at TMD, so that we should not, this is in the watch category, and you can easily develop resistance. And I'm worrying the trend which I see, being a microbiologist, that's meropenem, it might come a day where it cannot work. My supervisor for PhD, the one who first published a study on ESBL CTXM in Tanzania back 2001 or 2. That time there were very few isolates which were caused by SBL producing antibacterials. But now, if you look at this study, almost more than 80% of Klebsiella could be having CTXM15. So we need to do something, all this initiative, like aware classification. We should advocate that they should use less ceftriaxone and start with the access group of antibiotic before they move to watch and reserve group of antibiotic. So it's not easy, but we need to try, like in this facility which you are supporting, want to build the capacity of MS committee so that they should embrace, should take ownership of surveillance. They should use the data to update their local antibiotic formulary and advise the management that this is what they see. Because Fleming Fund is just supporting, but everything should be done local. It's not like a vertical program. This Fleming Fund does not operate like a vertical program. So we support the facilities, very urgent. They should do everything themselves. They should analyze the data and use data to improve patient care at their setting. We, like expert, we just offer technical expertise, what to do. Yeah. So I would say we should think of studies like the study which you are doing. You are trying to use informative biomarker to predict patient who are admitted to ICU and guide diagnosis so that we prevent before it happens. So we need intervention study, like maybe hand washing. Let's do clinical trial maybe. One wing do this one wing offer this one, and see the impact which could work in your setting. I'm really sick to see this burden. Every study acts burden, ESBL, ADM5. Soon you report colistin resistance. So, yeah.
Thank you for your work and healthy love.
Yeah. So thank you.
Thank you.